just as financial evaluation of it, to see whether it's sort of, helping, whether it's financially viable and be improved. Yeah.
I'd love to hear how they run it, but I know that's not what we're talking about today. So, but
I wouldn't be able to tell you
squeeze
that.
it in there.
I'll tell you after the evaluation how they run it.
yeah, fair call.
Got to come back. All right. Well, hi, Laurie. Hi, Tam.
Hi.
Hi.
And you pressed record, so we're started.
Nailed it.
Okay, we're ready to go. Okay. Well, shall I start with the intro then?
Yeah.
That would
happy
be
with that?
wonderful. Yeah, thanks.
So, well, Laura, it's lovely to have you with us on the Pelvic Health Podcast today. This interview was inspired after listening to you speak so brilliantly at our PB conference a couple of months ago. And I mean, we had such amazing speakers that day. And so the feedback was amazing, but I distinctly remember lots of people coming back going, I loved that talk from Laura Whitburn. That was amazing. And I was thinking about it. The content was amazing, but how you delivered that talk as well, I was like, that girl can present.
Oh,
lots to learn. So you began your career as a physio, like all of us, before transitioning into tertiary level education and research. And now you're a senior lecturer in anatomy at La Trobe University in Melbourne. Dr. Whitburn is also the president-elect of the Australian Society of Psychosocial Obstetrics and Gynecology, which we might get you to talk about as well, because I'd never heard of that until I learned more about you. Your research, I suppose, has been about understanding and improving the experience of labour pain and intrapartum communication, and that's been the primary focus of your research. You've worked towards a better understanding of the multidimensional nature of pain during childbirth and how a variety of factors influence women's pain experience. You've explored how effective communication between healthcare providers and birthing people can impact perceptions of pain and psychological safety during labour. Through your research, you have aimed to develop best practice that can be implemented clinically to foster more supportive and positive birth experiences. Brilliant. So I'll go ahead and ask the first question. Your PhD, I just remember listening to you a few years ago talk about it and just thinking, what a brilliant question. So from my understanding, you wanted to understand, first of all, why on earth labor is so painful. I remember you saying, like, it seems completely inappropriate that a woman should have to endure such pain to birth their baby. So that was sort of, from what I remember, part of your initial question. Yep. And could there therefore be a really good reason as to why we are physiologically designed this way? Yes. So can you tell us a little bit more about what inspired your original question for your PhD and then how you went about trying to answer it?
Sure. Yep. And thank you so much for having me on the podcast. I'm really excited because as a researcher, I can sort of chip away at the research and build the evidence, but it doesn't mean anything unless I can sort of convey it to those who are actually engaging with women and birthing people and make a difference. So this is one of those ways that I can communicate with clinicians and any, women who may be preparing for birth as well. So thank you for having me. Yeah, my PhD was such an exciting and rewarding journey, and it was because I got to choose this topic that I was so fascinated by. So yeah, as you know, I started my career as a physio, and I was just always really curious about pain. I was really curious about the individual variability between people and how they perceive pain and how context could shape their perception, and the placebo effect. I was always really fascinated about the placebo effect. And through all this, I always had this other lurking question in my mind. What about labour pain? It's often described as the most intense experience that a woman will experience, but it occurs in the context of this healthy physiological process. What? Why? What's its role? So I shifted out of clinical world and had this opportunity to pursue this as my PhD project, which was titled The Nature of Labour Pain. And it aimed to just unpack what is this experience like and why do women experience it so differently? With the ultimate aim to help improve the experience of it, help improve women's experiences of it. And at that time, about 20 years ago, things were starting to really shift in how pain was understood. And so the old ways of thinking and treating pain was starting to move out, and these new understandings were emerging. And I think this is good to talk through because this will sort of set the scene for then, sort of my PhD findings and the work I'm now doing. So, the old understanding of pain, which probably a lot of us began our education with learning about, was this sort of simple, direct message where pain signals sort of travel from injured tissues, and they are sent to the brain and they're read like a telegraph. And so, this idea of pain equals damage. And the problem with that, though, that was occurring was there were too many accounts of people having evidence of what would be tissue damage, might have scans or injuries, but they didn't experience pain. So there had to be more to the story. So we then progressed a bit from that, and we came to understand that the perception of pain could be altered by descending inhibition or amplification of that pain signal from the damaged tissue. So there could be pain signals coming in, but they could be gated. And that was the essence of the gate control theory of pain. But that then didn't account for people who experienced pain, but there was no evidence of tissue damage. So that sort of led to the question, well, where is pain being generated? Is it in the brain, which is where the next sort of iteration of pain science went? But that's still very tissue focused. It's just sort of shifting the pain from the peripheral tissues. I keep knocking my microphone. I'm not used to having this microphone in front of me. It just shifted the pain signals coming from peripheral tissue to brain tissue. And this is a really tricky question because it also raises some ontological and epistemological questions for us. But what we do know about the experience of pain is that it is multidimensional. It's not just a sensation. And so it's this complex experience, and it's loaded with emotion and cognitions. And we know that it's nervous system driven, but we need to sort of appreciate that it transcends brain and body and environment and context. It cuts through all those things. So it's really complex, but we'll come back to that because that's where I felt like labour pain could help us rethink pain in general and understand it in a different way. And so many listeners, many clinicians who may be listening, probably very familiar with the IASP definition of pain, the International Association for the Study of Pain definition, which says that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. I don't love this definition. I think that it's missing something really important. It's missing some key ingredients of pain, and it really doesn't work for labour pain. It acknowledges that tissue damage may only be potential and not necessary to have a pain experience. That's good, that aligns with pain science, but it still emphasises this idea of tissue damage being the sort of driver of pain or potential tissue damage, which in the context of labour, I'm really uncomfortable with. And I would prefer us to think about tissue changes that are happening during labour and birth, necessary and desirable tissue changes. And so that kind of makes labour pain not really fit the definition. And what the definition also doesn't emphasise is the social and contextual construction of pain. Pain is shaped by context and meaning. And this is where when I started to listen to women's experiences of labour pain through my PhD, this was so profound in shaping their experience. I think the other really interesting thing about labour pain that doesn't fit our usual conceptualizations of pain is that usually we think about pain as being an aversive experience, so something that makes us pull away or avoid or stop what we're doing in order to avoid danger or avoid potential injury. Oh my gosh, my glasses have just broken, sorry. I'll just balance them on with one glasses arm. I had them taped together actually, but the sticky tape has just broken. What was I saying? So yeah, we think about pain as sort of being this aversive experience. It helps us pull away from danger, but this can't be the case because labour pain, we need women to be birthing and we need them to not be pulling away from that experience, and we need them to go back for more. Otherwise we wouldn't have a human species. So it just doesn't fit. So it really forced me to sit down and think about what is this telling us about pain, the way that we just conceptualize pain. So I think about pain as a conscious experience that we feel when our nervous system decides that something needs our attention. Something's very important and urgent, and it requires action. That doesn't necessarily mean pulling away, but it just needs our urgent attention. And it's the unpleasantness of pain, which is what makes it a really good alarm system. Unpleasantness captures our attention. And the emotional component, that's what motivates us to do something about it. You know, if it was just a sensation without any emotion associated with it, we might just leave it there and not do anything about it. But the emotional component drives us to do something. And the cognitive dimension is what makes us decide what we're going to do about it. We need to know, what's this pain mean at this moment in time, and then I'm going to know how to respond to it. So with these thoughts in mind, sorry, this was a very long-winded way to answer this question. But yeah, so with these thoughts in mind, I set about exploring this, and I needed to do it through exploring women's accounts of labour through a series of qualitative studies through my PhD, where I surveyed but mainly did in-depth interviews with women. Because when you're dealing with a phenomenon that is ontologically subjective and socially constructed, you gain that knowledge through qualitative inquiry. So that was why I did what I did.
Amazing. And no one had done this before? Like, because obviously you have to then look at the background and do good literature reviews. And I assume you didn't find much, which is quite crazy now I think about it, that no one had thought to investigate before.
Yeah, even in childbirth in general, no one really started to ask women about their experiences until pretty recently, which is really astonishing. You know, that women were sort of just invisible in the experience, and their voices didn't really come out in the literature, and you know, until the sort of the last few decades, really. So there was unfortunately not much that had been done that had sought to actually get that knowledge and understanding of what the experience is like from women's experiences directly.
That's crazy,
well
isn't
done.
it? Makes sense though, given research on women in general, right?
Exactly.
Historically. And it makes sense when you say it like that labor, of course, should be painful, or else everyone would just go on with their normal life on the day of the birth, and no one would be alerted to the fact that it was a big momentous occasion that day. But then, yes, pain, so confusing. And I think we're understanding it more and more with time, and obviously with the help of you. And it is true that some people feel, I mean, it's meant to be painful, but what is pain? And some women feel so much pain, and others feel much less pain, if not no pain, and sometimes pleasure as well. Why? What did you find was the reasons that were coming out in your research for these discrepancies?
So it comes down to that multidimensional nature of labour pain. So we need to remember that pain has sort of a sensory component to it. It has an emotional component to it, and it has a meaning. And when we're asking someone about their pain, it's really to simplify it is asking them, was the pain 10 out of 10 or 1 out of 10? And I think that we dismiss a lot of the nuance in what that 10 out of 10 or 8 out of 10 or 1 out of 10 pain actually felt like when we just think of it as this sort of, this one-dimensional experience. So through my research, one of the major findings was the cognitive dimension and how it could completely change an 8 out of 10 pain from being one that was scary and threatening and negative to one that was empowering and intense, but incredibly purposeful. So that seems to be one big factor that can change and shape a person's experience. Is that person associating the pain with working towards the birth of the baby? So are they thinking about and conceptualizing the pain cognitively in this way that this is my body working hard, working powerfully to birth my baby? So it has this purpose to it, and in this way, your response to it is going to be, okay, I don't need to withdraw, be fearful or worried about this experience. I can go with it. As opposed to many other people who, through no fault of their own, because look at the way we conceptualize pain in general, it's something that's a warning of something going wrong. They associate labour pain with a warning of something going wrong, or this fearful experience, or this very negative experience. And so, an 8 out of 10 threatening pain versus an 8 out of 10 purposeful pain can completely shape that, that mean two very different experiences. And it also means that the support that, that 8 out of 10 threatening pain person needs versus the 8 out of 10 purposeful pain needs is really different. So this is where, probing a little bit deeper into what was that pain experience like is really important. But the other thing I think that is through no fault of their own, women are thrown into this environment to birth, which is not ideal. It doesn't help the birthing hormonal process, which has actually got this really clever inbuilt mechanism that supports women to deal with intense sensations. And I can talk through that because that's, I think, really critical and something that hopefully a lot of sort of listeners can take away from this is understanding the hormonal process that influences pain, and that can be shaped, can be manipulated, I guess, through the environment. So,
yes, please.
Yeah, sure. So we know that oxytocin is one of the main hormones of childbirth, and oxytocin is it's released by our brain, by our pituitary gland in the brain, and it travels to the uterus, and it's what stimulates uterine contractions. When the uterus contracts, this then leads to sensory feedback, and that's nociceptive feedback from the stretch and pressure of tissues in the pelvis, and that feeds back to the brain. And what does the brain do in response? It releases more oxytocin. So it's actually this positive feedback loop where contractions, so the brain releases oxytocin, contractions stimulate sensory nociceptive feedback, which stimulates more oxytocin, and we get stronger and stronger contractions. And actually that's telling us one purpose of pain here. It's got this this function in stimulating more oxytocin. So we need that nociceptive feedback, and in fact, women who have an epidural where they block the sensory feedback to the brain, their brains will slow down and potentially stop releasing oxytocin because there's nothing to stimulate, and often they'll need synthetic oxytocin to keep their labour progressing. So we've got nociceptive feedback, which is playing a really important role in this oxytocin feedback loop. But it's the other part of the story which I think is really powerful for women to understand, and that's that the oxytocin is also entering their brain. It's not just going down to the uterus. And in the brain, it's doing a few important things. It's down-regulating the sympathetic nervous system, that fight, flight, freeze part of the nervous system. It's down-regulating our amygdala, which is our sort of fear response component of the brain. And it's activating the parasympathetic nervous system, calm and connect part of the nervous system, and our reward systems. And this is really important because this means that that woman's going to get support and to help her feel calm and in control through as the oxytocin is building and the contractions are building. Then at some point, the beta endorphin system will also kick in. It'll kick in at a point where the intensity of nociceptive feedback is starting to really build. So then there's this second system that'll kick in, and that's the beta endorphin system, which are our endogenous analgesics. And they're going to start to kick in and also flood the brain, and they're going to provide analgesia, endogenous analgesia. And together with oxytocin, the most interesting part of the story is that they're going to trigger this non-ordinary state of consciousness, which is sort of like labor brain or the zone, or there's sort of different names that have been given to it. But this is really useful when you're in labor, because this non-ordinary state of consciousness is, we've described it as this sort of dissociative state. It helps you just withdraw from the environment, go into your body, but it also switches off the thinking brain. So you're going to switch off from those cognitive thoughts about pain and is this okay and what's going on. They all switch off, and you're just with the sensations and with your birthing body. And so that's where the environment can really impact women into whether they can get into that zone, because to enter that zone, and even the oxytocin system, it's very sensitive to adrenaline. Adrenaline is going to inhibit the oxytocin system and inhibit a woman from being able to enter this zone. So we need to make sure that adrenaline levels elevate during labour and birth, and that's normal, but we don't want adrenaline levels to elevate beyond what is necessary, because if they do, then they're going to start to inhibit this zone and the oxytocin system as well. So what stimulates adrenaline, and particularly in the most common environment that women are labouring and birthing in a hospital, bright lights, strange noises, strange smells, strange people, talking, being asked questions, being examined, being observed. It's just not ideal. We're putting women into this space and we're expecting her to be able to cope with this intensely powerful, overwhelming experience, and yet we're interrupting the whole system, the whole hormonal system that would allow her to do it probably very well and very confidently, but we're interrupting it. So that's where I think that the whole system, is working against women, working against the ideal sort of birthing hormonal physiology. But I do want to point out, though, that because ultimately it's about making sure women feel safe and undisturbed and feeling psychologically safe. And for some women, feeling psychologically safe is about being in a hospital. And that's completely okay. And it's about being in a hospital with 5, caregivers around them, and that gives them that sense of safety. But for other women, it is not. And for probably the larger majority, that is just going to be overstimulating, and it's going to increase adrenaline and going to interrupt that system. So I think that, yeah, we need to also help women prepare their environment to help them enter that ideal birthing brain, that birthing zone. And the environment needs to be the physical environment, but also the social environment, because she's also going to be very affected by what people around her say or do when she's birthing, and that's going to influence cognitively where she's at.
What about preparing her? Oh, sorry, Tam.
No, you go. No,
We're both sitting on the edge of our seat. Who's going to ask the next question? What about preparing her for the pain as a strategy, you know, to cope with it? Because, you know, I imagine, well, I know from experience, like when that pain arrives, it's shocking and can obviously be quite fear-inducing in itself.
Yeah.
So what are your thoughts on actually women really trying to understand the pain and all of this pain physiology in pregnancy?
Yeah, that's a really good question. I think that it's about planting the seed early, about questioning what they think about pain and what they think about pain associated with labour and birth. And there's this opportunity, I think, to reframe pain into this idea of this purposeful pain that is actually the body working really powerfully, sort of using analogies similar to, you know, you're doing a marathon and yeah, it's hard and it hurts, but it's your body working really hard towards this goal. Well, during labour and birth, your body's kind of doing a marathon physically and emotionally and cognitively. So it's going to be hard, but it's finite, and there are going to be lots of breaks within it as well, which I think that a lot of women don't sort of really think about and utilize as much. And think about pain differently. So it's kind of like reframing pain as this purposeful experience that is that is the body working powerfully. And I actually remember I started my PhD pre-children and had my first child in the middle of my PhD, and then my second one at the end of the PhD. So I gave birth to 3 babies in the end. That first labour, I remember I was at home and it was maybe 8 hours in. It was a long labour, and I remember having a contraction and then thinking, just get more intense, just get more intense. I was willing the pain to get more intense, and I remember then just having this moment of sitting back and thinking, this is weird. When else would you will a pain to get more intense? Labour. It's just so unique in that the intensity, the pain getting like worse in inverted commas, is actually my body telling me it's progressing and getting closer to the birth. And I think the only reason I did that was because I was on this PhD journey and I had this chance to start to reframe, you know, and unpick a lot of my own, you know, sort of the way that I had always conceptualized pain previously. So I think that that's one strategy that could really help women prepare. But the other thing is also letting her know that at some point her body's going to go into this zone. Her brain's going to go into this zone. And once she's in this zone, she's not even probably going to be, the pain will probably still be there. And we don't want to hide the fact that it's not still going to be, there's not going to be still lots of sensations. Her brain may no longer interpret them as pain, or if it does, it's probably not going to even be thinking about them because the thinking brain gets switched off. And I think that that's why a lot of women during early labour think, and I noted this in a lot of my research as well, they would say, in early labour, I was thinking, how am I going to do this? If this gets even more intense, this is only early labour, how am I going to do this as things get even more intense? But then by the time they've got into more established labour, their oxytocin and beta endorphins are now flooding their brain and their thinking brain is switched off. And that's good for them to kind of know that that's going to be going to be there.
It's good for the people around them to know as well that if they say particular things, then it could bring them out of that zone and into the thinking zone again. For example,
Yeah, that's
4
right.
centimeters.
You're only.
You're only. Yeah.
Yep. There's some really interesting research that has been done about women in the 3rd trimester of pregnancy, and they've shown that they're more hypnotizable. And one of the components of being hypnotizable is being suggestible, which means that you're quite responsive to words or cues that are given to you. That's what suggestibility is. And there's something about pregnancy and probably labor as well, and it's probably that hormonal system that makes women more sensitive to verbal and nonverbal cues. And I mean, you might even think of this. Yes, I remember during my own labor, just the implicit messages you feel like you're hearing from those little things that are said to you, and how they can completely pull you out of your zone or keep you in it. So that's right. It's so important for the people around the woman to realize that their words are going to be interpreted very implicitly by that birthing person. So they need to be careful with what they say. And I think that one of the most, and this is the work I'm now doing sort of post-PhD, is about communication and language and unintentional, nocebo language. Nocebo is the opposite of placebo. So it's the language and context that we create that actually can make a person's experience more negative or worse. And one of the most common ones is these little seeding messages of doubt through statements such as, let me know if you want anything for the pain, or you look tired, are you okay? Or are you sure you can carry on? I'm here if you need anything. Those statements are coming from a good place, absolutely. But what they're implicitly doing is they're seeding a little bit of doubt that woman is very sensitive to, that, oh, am I going to need pain relief? Is this going to get to the point where this is going to be too painful for me to manage? I'm not tired, but am I going to get too tired? Am I sure I can carry on? Actually, I don't know if I can carry on. So it's these little messages that unintentionally, potentially seeding doubt in the woman. And then the other ones, you're only 2 centimeters, it's only early labor, gives this sense of, oh my gosh, I haven't made any progress. I've still got ages to go. As opposed to saying something like, well done, you've already got to 2 centimeters. That's really hard work for your cervix to get to 2 centimeters. Or, yeah, this is early labor. You're in labor, you're on the journey. You've already done a lot of work. So it's also this kind of sense of time compression and expansion, or focusing on the progress made is really helpful. Don't focus on the time still to go, because that's just going to be discouraging. Yes, so language and communication is really important from those people around the women.
I just wanted to go back, but not really go back because we're already talking about it, with the environment. So we're not having a discussion about home birth versus hospital birth, but, well, I mean, it's in the background. However, knowing that, can we recreate that environment in a hospital setting that allows women to have all of these things that you would like them to have, and getting people to change the way that they communicate? But I just don't want people to then think, oh, okay, a hospital setting is not a good setting.
Yeah.
There's a lot of negatives about it, but there's also a lot of safe, positive things about it. So how would you go about changing the environment in a hospital setting?
I was recently, at the start of the year, I was a birth support person for my sister, who gave birth in a hospital. It's a lovely story, because I was at her birth. So I was 8 years old when she was born, and I was with my mum when my mum gave birth to her. And then she was one of my support people for my second baby. And then I was able to be her so I saw her born and her baby born, which was really lovely. But absolutely, it's possible to make that hospital space feel safe, private, and to just minimize any disruptions. They're probably the three sort of elements. Just make it feel safe and private and undisturbed, minimize disruptions for her. So it meant for her, we turned all the lights really low, and we had a salt lamp in the corner. She had her music on, so that those were the sounds, familiar sounds that she was hearing. We had a birth ball, which most hospitals are able to have some equipment like that, birth ball or shower or bath. She didn't have a bath, but we had the shower as well. It meant that anyone coming into the room was not going to just barge in and enter. They were going to signal to myself or her partner, and we were going to bring them in, sort of gently, and make sure that she wasn't sort of disturbed at the time. So I think it's absolutely possible in that hospital space. And some hospitals have family birth centres connected to them, which gives them that more homely environment. I think that thinking about my second birth, actually. I remember this was the one where my sister was also with me and supported me. And I remember afterwards, she was telling me about how this had happened in the room and that had happened, and then you're over, there, and then the ball popped or something, or, she was telling me all these events. I was like, what, really? I didn't remember any of it. And so the other good thing is that once the woman's sort of in that zone, she'll probably be less aware of what's going on around her anyway. And then it's not as, anything that has to happen in the space, which often does have to happen in a hospital, can happen, and it's less likely to disturb, particularly once that sort of the oxytocin and the beta endorphin system is fully engaged, and it's less likely to be disrupted through sort of adrenaline levels spiking. So I remember, saying to what there was an oil, like there was a salt lamp in the room. I don't remember that. We had the lights down. I just had my eyes closed the whole time. So I think that the hospital space can be made to feel as long as it feels safe, private, and she's disturbed minimally, then it's possible.
I think it takes a strong person to execute that. So we always try and educate the partners, but even still, you're trying to pump them up and say, you can do this, you can turn the lights off, you can say no to someone entering them. But in reality, I am getting around hospitals a lot now and listening to a lot of chit chat from OBs and midwives. And, they're all poo-pooing, the one that comes in with their music and their lamps and their da-da-da-da-da. So I think the reality is, I think in a lot of hospitals, you'll meet a lot of resistance, which is not at all to say don't do it. But I just think, for our listeners who are a lot of public health physios and health professionals, it's just making sure the partner knows that they're going to have to own the space and be really strong if they want to execute it in a lot of environments. Do you agree?
That's true. That's true. And that's where, because we ideally don't want the woman having to do that advocating for herself when she's trying to get into her zone and just focus on birthing her baby. So it's her support people who ideally need to take on that role of protecting the space and holding the space. It's also potentially a good reason to think about a doula. If a person has capacity to engage a doula, it's about having someone to protect that space. I had a private midwife, so I gave birth in a public hospital, but I had a private midwife because I wanted someone to be able to be my thinking brain and to be my sort of advocate. And my partner, he would try, but he didn't really know what he was doing either. And so that was our strategy. But I think that's we don't want the woman to feel like that's her job. So that's great that you're talking to partners about that. But yeah, even midwifery students who need to support X number of people as part of their education may be a really good option for just having another person there that's going to be consistent, that is going to have that ability to build a relationship with the woman and family beforehand, and will able to be there. Could be another good way to just help hold space during the labour and birth, particularly in a hospital setting.
Love it. I was at PB and listened to your talk, and I feel like I've never heard anyone say it, but it's what I've been thinking for a while. And that's this concept of changing the pain relieving strategies from pharmacological and non-pharmacological to intrinsic versus extrinsic, because I often ask people, so what are you going to do to, get you through the labor? And they'll say, I mean, it is all important, right? That's why it's all in the extrinsic category, but literally just a lamp, music, that's it, playlist, yeah. And I think that's great to set the context and the environment. However, if you are thinking at all, you probably won't make it. So you might need some intrinsic strategies, but I'd never heard it spoken like that. So can you tell us a little bit more about how you came to dividing it like that?
Yeah, sure. Yep. So you're probably starting to hear a common theme come out of my work, which is about language and words and how words are powerful. And this common categorization of pharmacological and non-pharmacological in terms of strategies a person might plan actually has a lot of implicit messaging in it. I think there's two sort of implicit messages that are coming across when we use pharmacological and non-pharmacological. The first is that it centers on pharmacological interventions as being like the standard, and that anything that's non-pharmacological is like an other, a sort of a secondary or alternative to the main focus, which is the pharmacological interventions. And then secondly, it assumes that when a woman is feeling like she's not coping, all she needs is pain relief. Instead of recognizing that while some women may absolutely need and want pain relief, what others might be calling out for is that they're not feeling safe, or they're not feeling in control, or they're not feeling supported, or then they're feeling undisturbed. So and if we think about, ideally we want her to be able to access this zone, this dissociated state where where coping is embedded in the system, then maybe we should think about strategies that she can use differently, because that's now the aim. The aim is to help her access that state. So we then thought about how can we recategorize then strategies, and we decided on this idea of intrinsic versus extrinsic strategies. So the intrinsic strategies were those that a woman can initiate and utilize autonomously. So on her own, she doesn't need anything, doesn't need any equipment, doesn't need any assistance from others. So these are things like breathing techniques or movement or vocalizations or meditations or mantras, things like that. So they are immediately available to her in her full control. She can utilize them whenever she needs. Then extrinsic strategies were those that might require some equipment or some support from other people, like aids or whatever, and that could include things like showers or baths or a TENS machine or massage or pharmacological pain relief. So by sort of reframing the strategies in this way, the intrinsic and extrinsic, now the focus is on on the woman's autonomy in the strategies that are in your immediately accessible to you, and then the strategies that you might need some assistance with. And so that's centering now on autonomy and control. And we know that's what we want women to feel in her labor and birth. We want her to feel in control in as much as she can. And it really highlights then, what she can do for herself rather than just the list of things that can be done to her. So that was where, we sort of went with that.
Sorry, love it.
Yeah, I'm like not meaning to be uncomfortable silence. Apologies for that. I don't have the
Let that
questions in
sink
front of
in.
me. Yeah.
Oh, don't you?
Joe, I don't have the questions in front of me, so I'm not sure if there was another
The
one.
last one was just
Yes,
about the
thank you.
take-home messages
Okay, yeah.
on how we can support women better in pregnancy and prepare them for the pain intrapartum.
Yeah.
Something
Laura,
like
this is
that.
brilliant. I love this. I'm so sad that I
know.
missed the conference. And I'm so happy that you're here talking about this because your research, again, like Joe said, brilliant presenter. And I could just sit back and I have this whole time and just let you chat and just listen to it all because it is absolutely brilliant. So thank you so much. So I will let you do the takeaways.
And that conference, Joe, was so brilliant. It was such a beautiful energy and space that you created. It was probably one of the favorite that I've ever attended. So yeah, it's a privilege to be able to contribute to the discussion. Okay, I've thought about these take-home messages because I want this to be sort of useful to listeners. So I've come up with 5 take-home messages to hopefully help. So the first we already sort of talked about, and that was this idea of reframing labor pain as purposeful. So explaining that not all pain is the same, and pain in the context of labor is the body's clever way of capturing your attention and keeping you focused on your body and signaling the powerful work that your body is doing whilst you're birthing your baby. So that's number 1. The second one I think is really useful for women to be explained that neurohormonal process. So help her understand that, for oxytocin to build, she needs to feel safe and private and undisturbed. And then as that oxytocin builds and the beta endorphins start to kick in, she's got this inbuilt pain relief and pain coping strategy built into her system. It's going to help her go into this laboring zone, and it's going to switch off her thinking brain. That's going to help her give birth. Thirdly is emphasizing and getting her to think about the social environment, and who's with her and what they're going to do and say to make sure that she does feel safe and she's entering that zone, and making sure that the people are not going to be disturbing her or unintentionally seeding any ideas that are going to seed doubt in her ability. Fourthly is this idea of, helping her prepare intrinsic and extrinsic strategies rather than pharmacological and non-pharmacological strategies, so that she's thinking about strategies that focus on her autonomy, what she can control and utilize straight away, and maybe some extrinsic strategies where if those intrinsic ones aren't working quite as well, I might also utilize some extrinsic ones, all in the attempt to get into that zone where pain relief and coping are built into the system. And then the 5th one was actually for any listeners who may be present as a support person or a care provider during birth, just thinking really carefully about your words and actions. And I'm going to be, we're going to be hopefully presenting sort of a framework of therapeutic and potentially harmful language very soon to help make this a little bit clear and give people ideas of what to say and what perhaps not to say, or what to be careful in saying. But some ideas of things to say are acknowledge and validate what she's saying. If she says, "I'm not coping, it's too hard," Don't jump into a reassuring, encouraging statement. First, just acknowledge, yep, I hear you. You're finding it hard. Then move on to some acknowledging, a lot of women find it hard at this point, but you're already doing it. You've already got this far. Well done. Let's keep going for another contraction. Avoiding any of those seeding ideas of not coping. So just being very careful with how you talk about pain or pain relief strategies. She's vulnerable. And in that moment, in my moment of labor and birth, if anyone had offered me an epidural, there's probably moments I would have said, yeah. It's a hard experience. So while we want women to know that options are available, we just need to be careful about how we offer them, and careful that we're not catching her at a vulnerable time where she'd say yes to something she does not want. And facilitating that holding space for her, which we sort of talked about earlier. So those were, sort of the 5 things: the sort of reframing pain, the thinking about the neurohormonal process, the getting her to think about her social environment, thinking about intrinsic and extrinsic strategies, and then for any support people or caregivers who are in that birth space, being careful with language.
Love it. Couldn't we sit here all day, Laura? You and I just keep going. What else? So good, but I know you've got to go work on your next project.
No, I'm happy to come back anytime and talk.
Yeah,
I
great.
feel like I've spoken a million miles an hour and wanted to cover everything, but be happy to come back anytime and talk a little bit more specifically about
Yeah, brilliant. What did you say you're working on now? You're working on that communication piece.
Yeah, that's right. Yep.
As in healthcare communication with healthcare providers, or
So a communication framework for maternity care providers. So that
Wow.
they can better understand what sort of language or communication, verbal and non-verbal cues, can I use that are going to be helpful, and what's potentially going to be harmful. Because we're just what we've noticed is there's a lot of unintended harm coming through miscommunication, or communication that comes across as coercive or threatening, or seeding, negative suggestions and seeding doubt. So we want maternity care providers who don't intend to do that. We want to help them understand a little bit more about that mechanism and give them alternative options.
Unreal. Oh, well, you can come and teach us about that. Fab. Well, thank you so much. Sorry it took us a little while to get here, but we got here in the end.
Oh, I know it did take a little while, but we did get here, and it was definitely worth it. Thank you so much.
Thanks both. It's been great.
No worries. We'll have a lovely afternoon, and we'll talk again soon.
Sounds good. Okay.
Okay.
Bye.
Thank you.
Right. See ya.
Bye. I'll stop recording.